Thank you very much. First of all, I'd like to welcome everybody to Bangkok, to the 14th TechNet Conference. We're now going to start the opening ceremony. I will first introduce our distinguished panelists who are up here on stage. We first have Dr. Richard Brown, the acting WHO representative for the WHO office in Thailand. We also have Basil Rodriques, who is the regional health advisor, senior regional health advisor for UNICEF for the East Asia and Pacific regional office. We have Dr. Piyanit Tharmaphornpilas. She is from the Ministry of Health of Thailand. She is also a WHO SAGE member. We have Diana Chandlan, who is a manager at the Program Operations Team of Immunization in WHO headquarters. Benjamin Schreiber, Senior Health Advisor at UNICEF New York. Next to Benjamin, we have Raja Rao, who's a Senior Program Officer for the Bill and Melinda Gates Foundation. We have Paul Colrain, who's next to Diana. He's a WHO expert in effective vaccine management. And at the end, we have John, Lloyd, and James Cheyne, who at some point in their life probably had one of those titles that I just listed, but now have actually reached the title of expert consultants who are, I don't think they actually really need introductions anymore. So let me just, before opening, let you just in on how this is gonna roll out. The first is we're gonna have some opening remarks and speeches from WHO and UNICEF and the Ministry of Health. And then we will then move on to some keynote speeches. First, starting off with a little bit of a history around the TechNet website, the conference, and so on and so forth. And then we'll have just some keynote presentations from Benjamin, Paul, and Raja to just give some context around the theme of this TechNet. And finally, I'll make a presentation just to walk you through what we've put together as an agenda and try to demystify some of the innovations that we put into a rather complex agenda. So, and I'm very, very sorry. I forgot to present Robert Steinglass from KSI, who is also presenting on behalf of IPAC. Very sorry, Robert, for that. With that, I'll pass it on to Richard, who's going to do an opening remark.
So, good afternoon. On behalf of the World Health Organization Thailand, it's my pleasure to welcome you to Bangkok for the 14th edition of the TechNet. The TechNet has a long history dating back to 1989, when this technical network of professionals and practitioners committed to strengthening immunization services was established, with WHO as its secretariat. Since 1990, members of the network have met face-to-face every 2 years in order to discuss key immunization implementation challenges, including those related to cold chain and logistics. As I'm sure you know, and as the tradition goes, the venue of the TechNet meeting has rotated to each WHO region. And in 2001, the Southeast Asia Regional Office, or CIRO, hosted the 8th TechNet Conference in New Delhi, India, where approximately 100 participants joined the meeting. So in 2015, the host region of the TechNet Conference returns to the Southeast Asia region of WHO. And it was a 14th edition here in Bangkok, Thailand for this week. And this time around, we're pleased to welcome I understand approximately 250 participants, although I also hear that nearly 400 actually expressed an interest in participating. And I think this is a real testimony to the growing network of professionals and practitioners that make up the TechNet community. But of course, it's also important to acknowledge that this conference, this particular one, is being co-organised with our sister agency, UNICEF. And I also might take the opportunity to say that in taking this work forward, there are many partners, including the ones that are supporting this meeting. I won't enumerate all of them, but you know who you are, and it's very much appreciated. And coming back to UNICEF, indeed, since 2014, WHO and UNICEF established a joint immunization supply chain and logistics hub, an initiative for enhanced collaboration between WHO EPI and the UNICEF Programmer's Supply Division, with the mandate to use the combined strengths of each agency to strengthen immunization supply chain systems in the countries. One of the pillars of the hub strategy is to build the community of practice for immunization supply chains, and this TechNet is one of the key ways to achieve this. Another pillar to improve vaccine logistics systems in countries as a key component of immunization and health system strengthening, and as a way of addressing equity gaps in vaccination and achieving future immunization goals. Combined, these were the key reasons for selecting the theme for this conference to be immunization, supply chain and logistics, current challenges, innovations and future prospects. And in closing, let me once again welcome you to Thailand and reiterate how pleased we are to be hosting this important event. I wish you all a very successful and productive conference. Thank you.
Thank you, Richard. I'd now like to invite Basil. Basil actually has a presentation to make, so
Good afternoon, everyone. Not really a full presentation, but a few words on behalf of UNICEF. Let me start by saying, on behalf of the UNICEF Regional Office here in Bangkok, and covering East Asia and the Pacific, as well as the UNICEF Office for Thailand is also based here in Bangkok, it's my pleasure to welcome you to Bangkok for the 14th meeting of the TechNet Forum. The meeting is jointly organized by UNICEF and WHO, and the collaboration has been excellent, I must say, among the sister agency, it was already mentioned, but also with all of the partners involved in the preparations and the funding that's been provided to support this work. I'm also very happy to see the WHO-UNICEF collaboration of the immunization supply chain hub taking shape and benefiting from increased recognition. Together, we are better working as a team. And together, we can do more than acting simply alone. This collaboration in the immunization supply chain is really important and will also be explained a bit further as I move on with this presentation. Looking at the agenda that's been set for this next few days, I can see that there's going to be a pretty exciting program that's been put forward. It is dense, but I think it's also very well structured. And I applaud those who worked to pull together this program, and I urge you to be on the lookout for new developments, as well as study findings, and there might even be a discovery of a new technology. A new way of solving bottlenecks as we've been identifying to support countries, as well as a new network of partners that may face similar problems that you will undoubtedly encounter in your country work. A network that you can leverage and a community of practice that you can share. But let me take a few minutes first to touch on a topic that is very, very important and dear to UNICEF, and it's the issue of equity and inequity. If you just ignore this very fancy title, my presentation has nothing to do with this. It's meant to be a distraction, but hopefully that you'll focus on the issue. The key word here is around equity. And I'll start with a very brief importance of the emerging hub. The coordination and collaboration platform between UNICEF and WHO. This work is very important as nothing is more confusing to our country counterparts than receiving advice that is not aligned among partners. The collaboration at headquarters level is established. And our regions are also involved. At the country level, we need to ensure that the immunization supply chain is strengthened as part of the general discussion of the Interagency Coordination Committee with support from a functional National Logistics Working Group. With those few words, let me once again say thank you and wish you a productive meeting the next few days. And again, welcome to Bangkok.
Thank you, Basil. I'd like to welcome Dr. Piyanit to say a few words on behalf of the Ministry of Health of Thailand.
Thank you, Patrick, and dear distinguished guests, colleagues, ladies and gentlemen. First of all, welcome to Thailand. And as the representative of the host country, I am pleased to greeting you here. And I would like to thank the TechNet team for selecting Bangkok for this year's conference. Other than there are more than 250 participants this year, and I'm glad to see several Thai and colleagues from the ASEAN countries. For many of the participants, including myself, this is the first time. But I hope we could take this opportunity to learn from our experienced colleagues and hope this will boost interest in immunization supply chain and logistics. It is very appropriate to have this conference in Thailand, and we have been changing our immunization supply chain and logistics lately. We have started since the year 2010. This is the major one. Our objective is to streamline it. We changed the organization responsible for vaccine procurement, as well as the rules and regulations for the procurement. We changed our whole vaccine transportation system, national and subnational vaccine storage. Pharmacists in our hospital are now responsible for vaccine logistics and stock. There is marked increase of private logistic company involvement in our system. These changes come with many good things, but also some big points. We learned that to maintain a good quality immunization supply chain and logistics, we only need to keep an eye on it. So the little problem before it becomes big. Every year it needs budget, and we need to have the vaccine logistic budget line, so the equipment can be maintained and upgraded, system can be evaluated, and necessary studies can be done. The recent challenge we have is the sudden increase of volume of vaccine because of new vaccine introduction and several immunization campaigns. At the moment, we have 3 vaccination campaigns going on simultaneously. 25 million doses of DT vaccine for adults, 3 million doses of seasonal influenza vaccine for high-risk population, and another 3 million doses of MR vaccine for preschool children. But amazingly, so far our system is still able to cope. I believe that immunization supply chain and logistics is actually evolving in every country. It will be very useful to hear each country share their valuable experience in this conference. At the global levels, as I am a member of SAGE, the Strategic Advisory Group of Experts on Immunizations, I was involved in the preparation of immunization supply chain sessions in November 2013 and April 2014, which raised awareness of the challenge that many developing countries face when it comes to procuring, storing, transporting, and handling vaccines. And that led SAGE to endorse a call to action last year, which you will hear Robert present to you afterwards. Although I believe we have raised awareness on this issue in the last few years, but still it is needed that the policymakers in each country also have awareness, and that is one of our tough tasks. Before I end my talk, I wish the group a very productive and satisfactory conference. Hope it plants a little seed of idea in mind of all participants make them go back with enthusiastic to start new work in their own country, and hope the TechNet networking grows stronger. For some of you who plan for holiday in Thailand after the conference, I wish you will enjoy it. But for some of you who have limited time, my advice is that we are in our summer, so it could be very hot most of the day with occasional thunderstorm. So it is a good idea to be inside the conference during the day. But for the night time, it will be interesting for you to explore outside. On the road along the SkyTrain line, there are lots of things to shop. And our shop close at 9 p.m. Some of them close at midnight. Thank you very much.
Thank you very much, Dr. Piyanit. And with those welcoming remarks from WHO, UNICEF, and the Ministry of Health of Thailand, I can now formally announce the opening of the 14th TechNet Conference in Bangkok. So we're now going to move to some keynote speeches that are just to give some context around the theme of this TechNet that we selected, which is around immunization, supply chain, and logistics. And to start this off, we're also going to welcome John Lloyd and James Cheyne, who are first going to give some context about the TechNet, the history of the TechNet, where it started, where it's evolved, and also pay tribute to a special person that worked on vaccine management and cold chain and logistics for more than 30 years and recently passed away. So with that, I'd like to invite both John and James up to the podium and look forward to hearing the presentations.
Yes, it's a double act. I've got a terrible reputation for speaking too long, so I'll rely on you to give me the T sign if I'm going on. James has to have his time. By my reckoning, the cold chain is just exactly 40 years old. I may be biased, but partly I know it because I've spent the last few days really having a good time. I've been in my home in Tharmaphornpilas, on my face in the middle of our sitting room, surrounded by nearly 100 kilos of paper. The paper is really a day-by-day, practically, account of the development of the expanded program on immunization for the last 40 years. It really is built of mission reports, and I've used it in order to share with you just some thoughts coming out of that, which I think tell us some lessons. So, so in this first slide, first of all, the slides are quite full, you'll find, and I'm not going to read them out, I'm just going to talk. So you're welcome to read them, and you'll see things which I don't necessarily enlarge. And I'd just like to say that when I say I do mean I. When I say we, I mean not WHO or any specific organization, but the partners of immunization that took part all those years to make the program work. So the top bar represents the 4 stages, the blue stages, 4 decades of the program. And you'll see that there's a slight hiccup at the beginning, which is the start of the expanded program on immunization. Reasons I don't fully understand. In May 1974, the program was launched, but the feasibility study, which set the scene for the immunization program, was in 1976 in Ghana. And that was when I joined and started to work. I think I was the second employee in the program. So in those days, you'll see on the left-hand side the partners of immunization were fairly narrow. I'm not saying there were just 3, there were certainly others. But WHO, UNICEF, and CDC were the most active at the beginning, and it was just a small band of people, really narrow. You see it's got 3 down. Now, that number of organizations grew fantastically over the 40 years. You see that the charts on the right-hand side begin in almost a decade and a half away from the beginning of the program. So during that time, we had no TechNet. The groups worked pretty much on their own. There was not a great deal of collaboration except among the working groups on immunization. So you see the chart with the bars on the right. That shows the first meeting of TechNet, which was held in Cyprus in 1990. And then you see the names stretching across to the right. Those are each of the meetings, including this one today. And the membership of those meetings, the participants, have gone gradually up and up and up. Until today, they've gone up really logarithmically. Similarly, the new registrations on the website, you see the website starting up much, much later. On the right-hand side, the box elevated a bit. And you see the graph there, the new registrations have staggered a little bit in past years, just the last 2 or 3 years, but it's picked up in the last year and a half very strongly. So in all, the pictures looks good. We've now got 75 active and participants in the program, not simply providing funds, but actually actively helping it. And it's growing strongly. And that's right. So now I think we can turn to the first of the segments of the decade. This segment, this 10-year segment, was extremely important, but it had some weaknesses too. The strength was that it was the development decade. In the field of the cold chain, there was a tremendously weak situation. There was really no standard training at all. There were equipment which were quite unsuited to the conditions in the field. So there was a lot of activity during that decade, and you see that I've pinpointed some equipment examples of development. For example, the refrigeration equipment, which we had to develop for areas with no electricity. Remember that in those days, in the African continent, for example, it's well over 70% of our health centres were working in areas with no electricity. So there was work to do there. And even where there was electricity, it was very poor, very weak, and broke a lot of times. So the Iceland refrigerator was very important. And there were cold boxes to transport the vaccine. I'd like to say that that equipment was developed on the basis of existing domestic equipment. Why? Because the manufacturers of existing domestic equipment made them very cheaply, made them at low cost. And in those days, the program budget was extremely tight. The countries were extremely conscious of cost, and it was important that it should be at a low price. And secondly, the manufacturers invested themselves quite heavily to make models specifically for vaccines. And then I'd like to say something about this portable steam sterilizer. The program was faced at the beginning with just using glass syringes and steel needles and boiling, and there was very little compliance with boiling. So that development program was to make portable steam sterilizers, and it wouldn't have happened had it not been in place for 11 years already in Brazil. So it's an example of where ideas came in for these technologies from other countries, and they were then mainstreamed for the main program. Then I'd like to point to the training materials that were worked on in parallel. Yes, there were training materials, of course, on refrigerator repair, on vaccine handling, logistics. But the striking thing was that we did not stop at vaccines at that time. The orange modules on the right represent just sort of samples of about 30 modules which were prepared for logistics of all the major interventions, public health interventions, represented by departments in WHO. And so the logistics of those departments, the distribution of drugs and so on, was all in those modules. And the intention was to have a primary healthcare-wide strengthening of logistics. Well, the 10 years went past quickly, and a lot was achieved in development terms, but what was not achieved was two very important things. First of all, we were not able to mainstream in the countries, to scale up. We did a lot, we prepared a lot, but we did not succeed to really get out to scale in the countries. And part of that was because although we had very strong collaboration with UNICEF in the early years in terms of the development of equipment, we did not have the capacity to actually reach out to all the countries. So the second decade, I'll try and do a little quicker. We were incredibly lucky with the second decade, or else actually UNICEF had it all in mind. We got to the early 80s, and we then discovered we had the propulsion of UCI behind us, and Jim Grant. And UNICEF was galvanized for about 7 years leading up to 1990 for the Universal Child Immunization. And they turned around and they saw that the program was really set up. The program materials were developed, they were tested, the equipment was developed and tested. There was an immunization schedule which was agreed and standardized. So UNICEF, with their field offices and with their communications, they did the most spectacular job at that time of scaling up the effort to full global scale. And they did it by using large countries as a stepping stone and scaling up in very large quantities of equipment to the countries. In parallel with that, other organizations worked in areas of operations research. And I'm not going to talk about this list, you can read it, but I just want to say one thing, that in many ways, one of the most important steps in operations research was looking at the use of motorcycles. Motorcycles had a very bad reputation for short life and actually accidents. And but the experience in some areas in Australia and in some developed countries, where farmers used them, and there was already a great deal of knowledge in that area. So what we did was to bring that knowledge together, and motorcycles were developed, were made to specifications tested in Australia for the African continent. And we demonstrated that with training and by making a partnership with an NGO in the UK who already had a partnership with industry. We linked the motorcycle racing days with motorcycles for health. And right to now, these motorcycles help to coverage being a fraction of the cost of four-wheel drives. Now, you see the first TechNet consultation coming up at the bottom there, a decade and a half, as I say, into the program. And in first place, UNICEF called for this TechNet consultation. Why? Because they were also aware of the rather narrow collaboration that we had at that time. And they called for grassroots participation in the program. They had many ideas, but they would be hosts of the first meeting. And the principle was that we needed to share more widely the implementation of the immunization program. And you see that numbers of participants over the years going up at the bottom there, from 1990 to 1994. Sorry, not too far. So the implementation was driven by UCI to a great extent, and the training was mobilized by regional training centers, and the scale-up of equipment was through large countries. So then we move on to the third decade, and after the 1990s success of UCI, I was describing it as a vacuum, kind of a vacuum of energy at that time. It wasn't that nothing happened, it was that everyone, for a moment, thought that they'd done the job. And many people in UNICEF and in WHO, and maybe other organizations too, felt they'd worked flat out to get to universal child immunization, and that, where was the next challenge? Well, they didn't have to wait long. The polio eradication initiative, of course, took off, and in the African region, it took off in 1996. And it brought its own needs. It needed equipment, it needed training, it needed logistics. So there was already quite an injection of energy there. And at the end of the decade, Gavi was born. Now these two actually brought with them a much more collaborative situation. Of course, we started TechNet, but the polio and Gavi in particular pulled together an enormous constituency of partners and participants. Now, the quality focus at that time, which was in parallel with getting the program out of the vacuum that it had been in at the beginning, the quality focus was really on unsafe injections. And it was very controversial to begin with, but in 1998 there was a key confrontation, a meeting on Nubi, just pre-SAGE. And by that time everyone was on board and realized that this was a very serious issue. The HIV infections were becoming a very serious worry in Africa. And all of a sudden, all over the hospitals in West Africa and East Africa, were WHO-sponsored posters on the hospital walls saying, do not use equipment which has been used before. You have to use equipment only once. And imagine our entire program was built around our steam sterilizers and sterilization. Now, we didn't have time to argue just what the compliance was with sterilization. So we moved towards disposable syringes, which of course can be reused. So, cut a long story short, you probably know that the auto-disabled syringe was then developed, and many manufacturers took part and competed in that. And there was a tremendous acceleration once the testing had been done for the introduction of AD syringes and they've become the standard for UNICEF and the partners. There was advocacy, and there was much work on disposal systems as well to ensure that syringes and needles were properly destroyed and managed. The mechanisms for these, for the safety of injections to get transmitted out was, first of all, joint statements were sent out. And these joint statements were signed by WHO and UNICEF, but they were sent round to all bilateral partners. And many of them signed up in addition, so we were able to get a kind of an agreement which stretched beyond UNICEF. And then, in parallel, there was the other areas which attracted statements and study and development. One of them was the EBSM. EBSM stands for looking after central stores, large primary stores. And the reason for that was that UNICEF did a postal survey at that time, which had spectacular feedback from the countries, and very worrisome feedback that the central stores were in very bad state. So a lot of effort was put into that. The growth at that time of bilateral funding was very great, and that led to, for example, Denmark providing a great deal of equipment to Africa, and the methodology that they introduced for checking the equipment needed in the countries was the very beginning of the methodology which we use today. Operations research was another area. So then we're coming on to the decade, and actually this is the most exciting bit really, and it should be. But really since 2006, we've actually begun to see a complete transformation taking place in what we called cold chain. We called it the cold chain because it was cold and because it was identifiable and because it was immunization and because it had bridges at each level. The entire system of distribution of drugs is also a supply system. And what we see is that the cooled drugs are increasing in volume and quantity in many, many countries, practically everywhere. So that infrastructure for distribution is growing. We also see that we always thought that our distribution systems were the best. We called ourselves the thin end of the wedge. Everyone would understand how to distribute drugs if only they could see how we distribute vaccines. Well, that was true, but things have changed. Things have moved on. With outsourcing and many mechanisms, private-public, many ministries of health now run extremely good programs supported by logistics and distribution. So the transformation I'm talking about is from cold chain to supply chain. And the way it can happen is because we have so many new partners, we have effectively an accelerated introduction, really to the level almost of a logarithmic increase in the number of vaccines that were anticipated to introduce. And that requires many partners, as we've seen. And that number of partners to transform the system sorry, just feeling my way. What I'm saying really is that the introduction of new vaccines actually brings a focus to a large number of partners And we realized that we're not any longer dealing just with the cold chain. We have to think of a complete infrastructure of distribution, including vaccines and drugs. There are managerial tools which were developed in this last decade, which start to help the process of looking at the efficiency of and the availability and important attributes of the distribution system. And we absolutely have to achieve an improved efficiency. Our first looks at central stores, the EDSM, has migrated into the most important evaluation tool that we have now, the EPM, the multi-country assessment, which actually drives our planning of the cold chain. And the EDM is just the start. It's really a picture of a new logistics planning effort for making the cold chain into an infrastructure. Optimize project, reset norms, and challenge dogma. Very much the Optimize project was a tool for making this transformation. And what can we therefore deduce from this? Well, there are a couple of lessons which are pretty straightforward. One is that we've seen that the power of collaboration, although a lot was produced in the first decade, the collaboration increase that we've seen in the last decade is a massive boost to immunization. It's an opportunity for us, and it's also a challenge. Of course, with more participants, we can do more. With more money, we can do more. But we have to be as transparent, and we have to be trustful, mutual trust. So, right. And the other thing that I think we've learned is that we've had among the most powerful champions in public health. We've had a number of individuals who have led us at various stages through our major initiatives. So we value champions. But we've been accused of being very vertical. And we have developed a vertical supply system completely. I believe that actually we cannot sustain separateness. We should not sustain separateness for very much longer. I think that the inefficiencies of siloed supply systems we cannot afford. That means is we have to make the logistics a common operating platform for public health, but that the public health leaders, the champions, should continue to be given full support to operate their programs individually. I'm taking too much time there, so I think that's the message. And then there are some, at the bottom of the slide, there are some setbacks. I'm just going to name them. I believe that the needle waste management and syringe and needle waste management, sharps management has to be addressed, and it's not being, it's sort of died. And it has to be addressed as part of the supply chain. That's the key to the solution for disposal. I explain why over time. Transport management has also taken back seat, and what we have now is, I would say, a large number of countries that state that they are on their knees with too few vehicles, actually have such mal-distributed vehicles that they have too many vehicles, in fact. So a massive effort is needed on transport management to properly distribute and look after this transport, if this common platform is to work. sorry, the last one. Where are we now? This is the principle of the optimized vision, the 2020 vision, up at the top there. And you see the legs of that vision, the major parts of the program in the circular chart. They are aimed at achieving 6 good things, rights of the program. But we will learn at this meeting many of the things that need to be done in the next decade, but possibly the most important is reaching the children who you just heard from UNICEF we are not reaching. Thank you very much.
Thank you very much, John. And it's an interesting evolution on the TechNet. You can see that it's grown from a small group of partners working on this back in 1990 to more than 75 different partners represented in the room today. Back 30 years ago, we're tackling a lot of issues that are actually still relevant today, and we're still talking about similar issues when it comes to logistics. And the evolution is quite interesting that it started off as logistics for primary healthcare to an evolution towards cold chain, vaccine cold chain. And now that we're seeing a trend towards terminology which we call supply chain, which is more than just a refrigerator. We're talking about human resources, people, data. Interesting evolution around this. And one of the there was a key person that was very much part of this journey and this evolution that I'd like to invite James to present a little bit about Andrew Garnett and his contribution to the world of logistics for primary healthcare, to cold chain and logistics, to supply chain, to effective vaccine management. James.
Thank you. I've got the extraordinary privilege of talking about an extraordinary career when he's talking about Andrew Garnett. How many people in this room knew Andrew Garnett or worked with him? Well, that's some indication to the extent of his work. How many people actually have heard of Andrew Garnett? Sometimes actually never met him. Rather few of them. Well,
James, could I just ask you to speak a little bit closer to this?
sorry. Okay.
Your talk.
Can you hear me okay now? Can you hear me better now, I should say? Okay, thank you. Andrew Garnett, sorry? Is that okay? Yeah. Andrew Garnett was a giant, absolute giant man who worked almost throughout the history that John's explained. He was a meticulous giant and he was a modest giant, in spite of his extraordinary achievements. He's probably influencing almost everything we're going to be talking about over these next 4 or 5 days. He's with us here today through his work. He trained originally as an architect. Nobody's perfect. He then, his first exposure to public health was when he went to Yoga in Eastern Nigeria as a principal architect to the Ministry of Health, what was then Gombe State. He was there to design health centres, rural health centres. He stayed there for a couple of years, working with the Ministry of Health in Western Nigeria. When he came back, Anthony Mattesley, who many of you know, encouraged Andrew Garnett to go to the mid-80s, what we called EPI briefings. These were briefings held then to bring in new people into the immunization world who had different experience from the typical people who worked in EPI at that time. And that progress has been going on ever since. Soon after that, he became a rapporteur for one of the early TechNet meetings. Here we are at another TechNet meeting so many years later. And soon after that, he was commissioned, the first commission, I believe, by WHO, to write test protocols for standby power for vaccine refrigerators. It sounds like a fairly familiar topic to us all. It's interesting that that first project he did actually set his course pretty clearly for the rest of his career in EPI. He worked in Mozambique. He worked in Tanzania, he worked in PDR Laos, PDR Korea, Mongolia, Romania, among other places. There's one story in Mongolia is that people who actually perform rather well in Mongolia, who produce rather useful information or rather helpful with the program, are given a bottle of Tuika spirit. Tuika spirit is something like grappa, which is 60% alcohol. And at the end of the consultation, which was a couple of weeks, I think, he and his colleague came back with 22 bottles of Tuika spirit. There we go. Now I'm going to talk about the other Andrew Garnett, who some of you probably won't know so well. When he was in Yola, one of the architect, of course, had to visit the rural health centres, the construction sites. This is a real problem because of the wide and narrow rivers, shallow rivers. Andrew then solved the problem. He built a boat. And he built a boat that you see there, which is run by a Citroen 2CV engine. And the cage at the back has a propeller which drives the boat forward. Andrew was particularly proud of the 2 or 3 pages of calculations he did to design the propeller, to make sure it was efficient and effective for the power output of this 2CV engine. He then not only designed it, he built it. He made the propeller himself. He was a practical man. He then went on to build 2 barns for his family, rebuild 2 barns for his family. The first one you see here is in England. He built a second one in Canada with his Canadian wife, Bonnie. He also, because of he'd done quite a lot of work in India, and he didn't feel he actually knew enough about the science. So he signed up to a University of London and got a postgraduate degree in biological sciences. He was not there to collect the award, the degree. His wife Bonnie went, and she told me that his professor of biological sciences told her that Andrew was the only student he'd ever had who at the end of the course knew more about biological sciences than he did. That shows that's an indication of how deeply, thoroughly Andrew Garnett went into any project that he took on. He also became a qualified glider pilot, and of course, as you can see here, was a hang glider pilot. And when he flew his hang glider, he flew high. And then he flew high in his work too. This slide here shows you 15 of the projects, of many more that he worked on over the period. I'm not going to go through them all, don't worry. And each one is a really, really important signal piece of work. As I said, is still driving what we're doing today. I'm just going to talk, in fact, it underpins, actually, I think, much of the work that WHO, UNICEF, the Bill and Melinda Gates Foundation, the manufacturers and the NGOs are still working on today. I'm just going to talk about 3 projects. Oops, sorry. Just these 3 here. The PQS catalogue that's already been mentioned this morning. Andrew Garnett, and Ubin Khartoum made the transition from the original product information sheets to the PQS system we see today. And that's an extraordinarily complex process. It's complex for WHO, it's complex for manufacturers, but it's working. That's the point, but it's still working, it's still developing. It was largely built by Andrew Garnett and his colleagues in WHO. The second one, which we've also heard about already, is the WHO UNICEF effective vaccine management. Now, that wouldn't exist without Andrew Garnett. He did such an extraordinary amount of work over 2 or 3, maybe 4 years, I don't know, a long time. He not only wrote nearly all of the 500 questions, he developed all of the standard operating procedures. He developed the training, he ran the training, he modified the training, and rewrote it again. Finally, he actually wrote the software that this EVM, so the effective vaccine management system, is used now every day in all the countries countries, and we're going to hear about the 70 countries where it's already been run in a few minutes. That was Andrew Garnett in detail. He not only detailed that, he actually never lost sight of the big picture. The bottom one here, I can hardly say, generic preferred product profiles for vaccines. This is a recently developed project document from the WHO, which was very largely developed by Andrew Garnett. He was just an extraordinary amount of money. He worked quietly, and he always made his visions, his opinions clear, quietly. I know because I was there. Some of it was directed at me from time to time. And then shortly before Andrew died, he actually wrote a letter to his family and friends. And I'm going to quote from that letter now. And he wrote, "Don't be sad. When I started as a student architect, I never dreamed that I'd end up in the remote field of international public health. A completely unexpected privilege, and the most rewarding period of my working life. Thank you all to my colleagues and friends who helped and encouraged and steered me along this winding path." He ended, "Keep on singing, never, ever give up." On that point, I would like just pause for a few minutes of silence, a few moments of silence, thinking about Andrew Garnett and the contribution he's made to immunization over the last 30 years. I'm not going to ask you to sing, as Andrew's proposing. What I am going to ask you to do is to stand up, please. Stand up. Put your hands together. A round of applause for that.
Thank you very much, James. And I think all of us who raised our hands earlier were expecting to see Andrew with us in Bangkok for the 14th TechNet Conference. And instead of that, we've decided to dedicate this conference as a tribute to Andrew's work in honor to a lot of the ways he's touched us in the world of supply chain and logistics. So thanks very much for that. I would like to now welcome Robert Steinglass, who's not only a person who's been working on immunization for probably the last 3 or 4 decades. He's also a member of the IPAC and at the origin of a call to action to raise awareness of issues around supply chain, that inattention that John was presenting in some of the decades towards the end of his presentation. So I'll hand it over to Robert, who's going to present a little bit of the history around the call to action for a neglected but essential system in terms of supply chain and logistics, which I believe is at the origins as to why we decided to make a theme issue of a theme topic at this conference. So Robert, over to you.
Thank you, Patrick. So I'm going to explain about this call to action, as Patrick has mentioned, how it was conceived and where it stands today. As you can see, we felt that this was a neglected area, the whole supply chain for immunization, but it was essential and it wasn't really being recognized sufficiently. So I'd like to thank WHO and IPAC for the opportunity. And just to mention, I started my career in smallpox eradication. when I moved to the expanded program on immunization, which was new at the time, to become, as they call it, operations officer. So the challenge then was conceived as being one of operationalizing and customizing global policies and programs. And I don't think that's changed. I think that is still largely the challenge facing us, is how to operationalize what we're trying to achieve. I want to give you two anecdotes. My own personal wake-up call, which was a few years ago at a measles meeting, where several people stood up and thanked UNICEF for having provided the logistics for the campaign. I scratched my head trying to think, what do they mean? I found it very distressing that the difference between logistics, or I should say the difference between supplies, which is what of course they were referring to, which were provided by UNICEF, the difference between the supplies and the technical area of logistics was not better understood after 3 decades of the immunization program. Another wake-up call for me was in reviewing Gavi documents several years ago, where it was so obvious that there was an imbalance. The focus was on vaccines alone, as if the vaccines delivered themselves. There was no attention given to improving the supply chain through which annually $1 billion of Gavi purchased vaccines were passing each year. And when the cold chain was discussed at all, it was always in terms of the hardware and the equipment, and very rarely beyond the equipment to the software, to the people and the policies and the procedures required. So IPAC and SAGE are 2 of the advisory committees. There are others that advise WHO. There's a strategic advisory group of experts that Dr. Piyanit is on, is the principal advisory group to WHO on all things immunization. They report directly to the Director General of WHO. The Immunization Practices Advisory Committee is relatively new, 5 years or so, and it's an external and independent group of experts that advise WHO on the formulation of immunization practices and operational standards to improve service delivery at the country level. So we deliberate over such things as multi-dose vial policies, BVMs, control temperature change, other programmatic issues. And we report to the director of the immunization program, Dr. Lloyd, and we also provide updates to SAGE. So IPAC was deeply concerned about the relative neglect of the supply chain. So about 2 or 3 years ago, at a side meeting during one of the IPAC meetings, we decided to do what we could to generate interest in this area. We've had a number of conversations since then, and we've also come to the realization that the vaccine supply systems haven't kept up with the new challenges. And we haven't also kept up with developments elsewhere in the health system beyond the vaccines. And yet we were faced with new and greater challenges, bulkier vaccines, more vaccines, expanding populations to reach, increased scope and complexity of the storage and transport requirements. We also were discomforted by the fact that we were trying to handle these things in isolation. We were trying, in fact, to always put band-aids on problems and approach the problems in a piecemeal fashion rather than in a strategic one through the entire health system. So we helped document some of the serious consequences of that siloed approach, and also focused on some of the vaccination-specific consequences in terms of gaps in coverage, poor quality service provision, and inefficiency and wastage. I find myself often having to remind people that in order to control disease, and of course that's the function or the purpose of immunization programs, that immunization must overcome operations challenges day in and day out. And of course you all recognize that. You know what all of the steps are that are needed to get potent vaccine from the manufacturer to the individual. You understand what it takes to create and maintain a continuous, what I call slow chain, a continuous slow chain which reaches kids every day with good quality vaccines in a timely way before exposure to disease. Without over-reliance on what I call a fast chain, which is what's used, of course, during the occasional mass campaigns. And there's a difference between a cold chain and a fast chain, or a slow chain and a fast chain. So our programs have attracted much more attention than in the past because of for a number of reasons. The high visibility of new vaccine introduction, the fact that presidents and prime ministers in some countries are engaged in the process of new vaccines introduction, lots of money flowing to purchase new vaccines, countries spending more of their own money on new vaccines. So not a month goes by without somewhere the media sounding the alarm when large quantities of vaccine either are wasted or in short supply. Here's just an example. In the 4 previous months, Ethiopia in April, Pakistan in March, Ghana in February, and DR Congo in January, with the press calling attention to poor quality supply chain and resultant loss of vaccines. So here's a slide showing the pace of acceleration, which is increasing for vaccine introductions. On the left, you can see the 5-year period where 62 vaccines were introduced. In the next 5-year period, 140 were introduced, bringing the cumulative total to 202. In the next 4-year or 3-year period, 141 introduced, and now in the current 2-year period, 227 introduced. So you can see 227 compared in just a 2-year period compared to the earlier pace of introductions. So things are picking up. And we've, of course, discovered that more storage space is required for the new vaccines. Look at the stack of vaccines in green, which were the basic EPI vaccines prior to 2000. It took about 28 cubic centimeters to store the vaccines that would fully immunize a child. Pentavalent vaccine was introduced in 2004, adding another 41 cubic centimeters of storage space required, bringing it down to 69 cubic centimeters. Pneumo, the first generation, quite bulky in yellow, 41 additional cubic centimeters. The first generation of Rota was very, very bulky, packaged for first world use, single dose, large boxes, adding a lot more storage requirement, 156. So we were just running out of space in the cold chain. Human papillomavirus vaccine, IPV, more recently. So 327 cubic centimeters compared to 28 when we began just 15 years ago. So an increase of about 12 times per fully immunized child. The SAGE recommendations have had huge cold chain implications. We have these great life-saving vaccines, but the introduction of the life-saving vaccines has stressed the system, exposing cracks in the system. So the availability of existing vaccines is also a challenge. Out of 194 countries, the joint reporting form shows that the national vaccine stockouts in about 50 to 60 of them with chronic shortages. 50% of the lower and lower middle income countries, in fact, have faced national vaccine stockouts in the past few years. And there's no apparent pattern to the slide, either to the graph. If these stockouts affect all of the countries at different levels of economic development, there's no consistent pattern. And is fluctuating from year to year as well. But we can expect that as data quality improves, as we all hope, we'll see better reporting of stockouts than we have in the past. And what we hope to see is that as there is a blip up showing better reporting, that it will soon follow with improved quality of stock management. The EVM, the effective vaccine management, assessments have been done in 70 countries. You're going to hear more about this later. These are the 8 component areas that are assessed or evaluated. And you can see just how few countries achieve even minimum standards. The best performing area was storage capacity, where 43% of countries exceeded a minimum standard, and the lowest is maintenance systems, where only 8% of the 70 countries were able to achieve the minimum standard recommended. So the EVM assessments have brought new rigor to evaluation and have revealed widespread system deficiencies and serious neglect. The EVM, of course, compensates for a lack of routine monitoring, and we want to improve the quality of routine monitoring, because without that, you really can't have a better management program. We can't rely only, in other words, on an EVM from time to time. The new realities for today and the future, this compares 2015 against 2020. You can see how the cold chain storage required has or will be increasing fourfold. The value of at risk inside of the cold chain will be increasing fivefold. More doses to order, store, handle, and transport, sixfold expected increase, and ready inventory at risk to be managed. And by the way, I should mention that in 1980, the world's population was 4 billion, and in 2010 it was 7 billion. So we also have the challenge that we face to immunize more kids, and also not just kids, but people over the entire life course. So we felt that this inattention to the cold chain needed to be called out, and that a more unified approach to address it was warranted. The cold chain that we know was developed from a simpler time, but as I said, it grew piecemeal, and now we're trying to fix it at a higher level than what we've done in the past, which are supply mandates. So a working group of IPAC members led the development of a call to action. We felt that what was needed was an authoritative statement, which was going to be useful as a brief for policymakers, but with enough detail to indicate useful directions. And we wanted also to encourage change that would be led by national corporate managers and also those working at local and regional agencies. So the call to action represents the consensus of the entire IPAC, meaning it's a call from independent experts with a strong field orientation, going beyond WHO, Gavi, and UNICEF, who of course have reviewed and revised and unanimously supported the call. That call for action was endorsed by SAGE this past year, and it doesn't go into all of the level of detail that, for example, this document, which is well worth reading, does, which is developing a vision for immunization supply systems in 2020, which came out of the WHO Gap Optimized project. And you can see here all of the additional areas that need to be focused on. The call to action recommendations, there were two sets of recommendations. The first were directed at the national immunization programs to have better measurement, monitoring, and evaluation of the immunization supply chain logistics system, implementing routine information systems, and applying EVM and the improvement process. And then the second set of recommendations at the national level were to plan and implement those improvements, including strengthening supply chain interfaces that increased data visibility and flexibility. I should mention here that we also felt that there's a need for better continuous local information that is less reliant upon the occasional EVM. We also developed a menu of useful options to aid at country level for the country managers to do their advocacy to generate local resources for policy improvement. The next set of recommendations were directed at the global community of partners to increase awareness and investment. We felt that we could use new vaccine introduction as an opportunity to document the deficiencies and to demonstrate the need for greater investment. We felt, address supply chain systems when we formulate immunization recommendations. That has not always been the case. We need to harmonize supply chain systems and avoid missed opportunities. We have to look for opportunities to link and harmonize supply chains across all of the health sector beyond immunization, because we all share many of the same challenges and solutions. And then we have to identify and resolve knowledge gaps and accelerate learning. The aim here is to keep immunization and supply chain logistics on the radar when considering innovations and when we consider what else needs to be done to improve the program. So, there have been many manifestations that the call has been heard. The call to action has catalyzed many of these bullet points here and other welcome changes as well. I think there's more recognition now that we need increased investment, increased country ownership, and coordinated partner support. And with the renewed attention, we're seeing more hiring, more investment, and I think better thinking. So before I go to my last slide, I just want to take the opportunity to invite you on Wednesday at lunch to a roundtable that JSI is doing. It's your chance to contribute to a discussion on the optimal number of doses per container for vaccines. A topic that's been around for a long time, but I think we can benefit from hearing your inputs. And the discussion is going to influence the agenda for an upcoming partner discussion on the trade-off among the various vial sizes. That's Wednesday at lunch. But let's hear more. We have evidence. We're going to hear evidence that gave IPAC cause for concern. We're going to hear two presentations. Benjamin Schreiber, UNICEF, and Paul Colrain at WHO will be telling us about some of the additional causes for concern. And then we're going to hear from Roger Rao at the Gates Foundation on some evidence that the call to action has been heard. They'll present on the global perspective on immunization supply chain prospects and opportunities for the future. Thank you very much for your attention.
Thank you, Robert. I'd like to invite Benjamin to the podium. So we've heard from John his walk down memory lane over TechNet. And really, the bottom line is we're still facing a lot of the same issues that were discussed 30 years ago. And we heard from Robert how a WHO committee wanted to call out the inattention to this and the fact that many countries, many developing countries, are struggling with their supply chain systems. And we have limited evidence of these things. We know about it, we hear about it, but what is that evidence? What led this IPAC committee to make this call to action? So we're going to have two presentations, the one from Benjamin, who's going to take us through the photo safari, I guess, to see some of the anecdotal maybe evidence, which you will see it through images before Paul gives us some of the hard numbers. Over to you, Benjamin.
Okay, I hope you can hear me well. It's actually, I just realized I didn't change the automatic animation, so sometimes I jump quicker than I can talk. Are there any epidemiologists in this room? Not a single person, one person?
One behind you.
Great. So you know the stage, right? The stage is like lots of epidemiologists, and epidemiologists are great because you guys take like decisions based on evidence, and that's really good. But what happens if you take, and you use data, but if you take more than two epidemiologists in the same room, they don't look at the data anymore. They start discussing underlying methodologies, sampling techniques, correlations, and they don't take the decisions anymore. So when we want to go to the call for action, we thought like, what is the one thing they cannot discuss about? So we thought about, okay, there's one thing which is maybe very visual, and that's a photo safari. So we went to the stage with this photo safari, and I will do this again here now. Because we thought it was a good complement to the data, and Paul will show some of the data. So when we talk about immunization supply chains, these are really the backbones of the program, and we have the international level, and then we have the national level. And the national level starts really from the national store all the way to data going back up to international forecasting and up to the manufacturers. So we've heard the supply chains have been around for many years. They've been taken for granted. Somehow with these supply chains we managed to get some coverage rates. So things seem to have been okay. But then, as we will see in a moment, there are issues and there's data showing really some serious issues and concerns. And also we see this actually when we go in the field. When we go in the field, we have more and more vaccines arriving, and some countries get up to 20 shipments of vaccines arriving per year. this is really, can clog up really the national warehouse on the arrival. Also, these vaccine shipments are big. You know, some of these containers are 2 meters tall, very heavy. We actually need forklifts to transport them properly, and many countries don't have forklifts in the national warehouse, so they need to be put into place by several people, and then all this material that is accumulating, all this wastage, how do we deal with that? We don't have a very good idea, but we put more and more vaccines towards these countries. And the storage capacity there, the countries are, many places are really filled up with not enough storage, cold chain equipment storage. And so people try to make things meet, but if the shipments come at different times, so it's sometimes at the same time, then we have a problem. Temperature control, we're going to talk a lot about this here. The issue of freezing as well. More and more freeze-sensitive vaccines are being used. And some of these, this is a picture from a cold room, which is definitely frozen. Maintenance is another big issue. This is a picture from a cold room where the door is not locking properly. You see sellotape around, sort of fixing here, fixing everything, and many countries don't have properly maintained cold chain equipment. It's another topic we're going to discuss here in more detail. Maintenance remains a major problem. Distribution, often neglected. Tomorrow will be discussed. But distribution is a key element of bringing vaccines beyond from one level of the health system to the next one. And where do most temperature excursion happen? It's during this transportation. So it's something to be looked at, and we still distribute vaccines in places which are hard to reach, which have very big infrastructure. So there's not challenges just not in the supply chain, but just in the total infrastructure of it. When we look then at the health facility, we're dealing sometimes with very old equipment, so this is a quite, you can see this fridge in many places, but it's old, sometimes 2 or 2.5 decades old, and we use still inefficient kerosene and gas absorption fridges sometimes when new, better technology is available. Human resources definitely, they are the ones that really deliver the services, but they have to sometimes carry more and more products that we bring into the system. And also, the more products we bring in, the vaccine management sometimes gets more complex. So health workers are really the key and will be a major topic also be discussed. Vaccine management. The great things about the VVM innovation is that people get alerted, visually alerted towards cumulative heat exposure, but it sometimes makes it shows the problem, it makes it very, very visual, and sometimes you realize how poor some of the vaccine management is. It's sometimes frightening as well if you look at this. And sometimes here's a picture of poorly vaccine management of vaccines. In October 2010, these vaccines ran out, their due date was long over, and they are still being administered. Plus there's mold collecting on them. So that shows that they were maybe improperly stored. The huge issue of vaccine management, wastage of syringes, safe disposal of these products, still very neglected, and definitely I hope something we don't discuss in this TechNet, but maybe in one of the next months we have to really pick up on this. And then something which will be discussed in this TechNet meeting is really information systems. We all want better data, but if you go to the health facility, there is often no computer. It's one program and another program asking for reports, and health workers spending several days sometimes just on reporting to all the different programs, immunization just being one of them. Paper-based, error-prone, so definitely huge issue to improve. Okay, that was it, my short photo safari for now the real data comes. Thank you.
Thank you, Benjamin. I'm sure, thank you for this photo so far. I'm sure most of you can can relate to all of those issues you saw in the photos. I'm sure all of those are familiar to you. But it's hard to call out the inattention when you go up to the global level in front of stage and say, here's a photo safari, we have a problem. They kind of need more harder evidence and better data. And that's sometimes hard to come by, but Paul's going to show us that through the EVM, we're starting to build up some hard evidence around issues that we're facing on basic vaccine management. Over to you, Paul.
Okay, thanks Patrick, and good evening everyone. Okay, I'll give you a very brief introduction to an analysis that was conducted by the WHO UNICEF hub, supply chain hub, of the EVM assessment data that was collected between 2010 and 2013. Now this is the first publicly available assessment of the raw data for over 70 countries. And the analysis, the plan is to conduct the analysis every year, to update it every year. So the first update will be sometime this summer when we'll add the 2014 data. Now this is just a brief introduction. If you want to see the full slide set, you can download it from the WHO website, and I think it was also posted on TechNet. I'll give you the last slide has the URL for the WHO website. Okay, so the EVM assessment assesses all levels of the immunization supply chain, from the national store all the way down to the health facility level. And it assesses 9 different areas of vaccine management, the so-called EVM criteria. They are vaccine arrivals, temperature monitoring, storage and transport capacity, buildings and equipment, preventive maintenance, stock management, distribution, vaccine handling, and information systems. So there's 9 separate areas of vaccine management that are assessed. Now, the assessment is conducted by selecting a representative sample, randomly selecting a representative sample of sites at each level of the supply chain. And then at each facility that's selected, we evaluate over 100 indicators, binary yes-no indicators. And these indicators are then combined to form a score for each area, for each of the 9 areas, for each facility. And then for each of the selected facilities at each level, we combine the scores to get criterion scores, 9 scores for each level of the supply chain. Okay. So this map shows the countries that have conducted EVM assessments between 2010 and 2013. I think there's 75 countries, 4 of which have actually conducted 2 assessments. You can see that there was actually a surge of uptake around 2011, and this was partly due to Gavi making it a requirement for those countries in receipt of vaccine support to conduct an EVM assessment every 3 years. So we're getting the second wave of assessments starting now, starting in 2014 and continuing in 2015. So most of the countries you see on this map will actually have conducted their second assessment by the end of this year. And this should allow us to then actually start looking at improvements within all of these countries over the last 3 to 5 years. Okay, I'll show you a couple of slides now showing the high-level criterion scores across these 70 or so countries, and then we'll look at a few of the raw indicator scores. Okay, so the picture from this slide is not immediately apparent, but what we have here, there are 33 scores produced by an assessment. Right? There are 9 criteria and there are 4 levels, that's 36. But E1, vaccine arrivals, is only assessed at the national level. So there are a total of 33 scores that come out of an EVM assessment. The 9 areas across 4 different levels. And what you can see, and this box and whisker, for each of these 33 areas, you can see what's called a box and whisker. The central data point is the median score of the 70 countries. The box shows you the central 50%. The whiskers show you the maximum and minimum scores amongst those 70 countries. So it's immediately apparent that there's a broad range of performance. In all of the 33 areas, the median country does not meet the 80% score, apart from storage capacity at the national store. right, which is above the red line. So that says that just more than 50% of the countries assessed have a national store with enough space to store its vaccines, diluents, safety boxes, syringes. Right? But in all the other areas, the median country is below the minimum standard. You can also see that the weakest of the 9 areas are E5, preventive maintenance, E6, stock management, and E7, distribution. Right? These are the three weakest areas, and I think one of Robert's slides showed the same thing. And you can also see in E5 and E6 that the performance actually deteriorates as you go into the supply chain, as you move from the national level down to the service point level. You see that the scores actually get lower. Okay, this map shows the relative performance of the countries that have been assessed. The dark colour is the lowest quartile, so that's the lowest scoring 25% of countries, and the light pink is the highest performing 25% of countries. There isn't any pattern immediately discernible, apart from the fact that, as I'll show later, the emerald countries and the euro countries, on average, perform better than the countries in the other regions. Okay, I'll now look at 3 or 4 of the criteria across the regions, just to show you the range of scores across the regions. I don't have time to go through all 9 of the criteria. So, E2. This shows you the E2, the distribution of E2 scores, the box and whisker for each of the 4 levels in temperature monitoring across the 6 different WHO regions. Now, for some of the regions, there's not a lot of data. For example, you can see for Emerald, there was only 4 assessments, so you should take the results with a small pinch of salt. But you can see that at the lower levels, those 4 countries in the Emerald region, they all exceed the 80% target in temperature monitoring. And you can see also that in the Euro region, the countries also, most of the 10 countries assessed in the Euro region exceed the minimum requirement in temperature monitoring. One other thing you can see is that for the primary level, the black data points, the scores are relatively low. This is because the requirements at the national level are much stricter, given the high volume of vaccines stored at the national store. So there's more requirements there, so the scores are relatively low. But you can see still that countries are struggling to meet the minimum temperature monitoring requirements at their national stores. So as Robert and Benjamin showed you, maintenance is one of the biggest issues, and the EVM scores show that. The scores for maintenance are very, very low. The only kind of place where the scores seem to be good, where the preventive maintenance programs seem to be sound, are in the Emerald region in those 4 countries at the national level. Everywhere else, countries are struggling to meet that minimum requirement in preventive maintenance. Similar kind of story in stock management. Here again, like maintenance, you can see that within each region, you can see that the scores get lower as you go down into the supply chain from the national level to the service point level. And again, the only countries meeting this standard are the Emerald countries at the national level and at the subnational level. Lastly, vaccine management. Now this area assesses the knowledge of the staff, the store managers and the health workers on basic vaccine management, things like multi-dose vial policy, the use of the vaccine vial monitor, knowledge of the shape test. Right? Things like that are assessed here, and you can see again, same kind of pattern. The Emerald and Euro countries, the staff, the knowledge of the staff is good. In the other regions, there's lots of room for improvement, and there's broad, I mean, some countries are good, some countries are struggling. Okay, I'll now show you some of the raw data, some of the raw, the questions that are asked at each facility are used to form these indicator scores. So I'll just pick out a few of the most important ones. So we divide all of these indicators into 3 groups: availability, quality, and efficiency. So depending on their likely impact on the availability of vaccines at the service delivery level, on the quality of those vaccines, that's the potency, and lastly on the efficiency of the supply chain, so the kind of programmatic costs. So this first slide, the three highlighted show you that stock management is a big issue. Right? More than a third of the facilities at all of the levels have inaccurate stock records. They do not match the actual stock levels within the facility. And the vaccine stock levels do not match the diluted stock levels for those lyophilized vaccines. And also, a third of all of the facilities at all 4 levels have experienced at least one stock out in the prior 12 months, right? Meaning that they weren't able to meet the demand from the lower level facilities. So here in this, here's 3 quality indicators I've highlighted. Only 18% of countries have conducted a systematic temperature monitoring study, which is one of the minimum requirements, is that you study your supply chain to identify the weaknesses within the supply chain in places where vaccines are put at risk of temperature damage. Only 18% of countries have actually, at the time of assessment, this might have changed since, but at the time of assessment, only 18% of countries had actually conducted a systematic temperature monitoring study. Also, only 20% of the cold rooms have temperature mapping studies available for the cold room to identify regions within the cold room that are suitable for storing vaccine. And on the positive side, refrigerators, most of them, more than 90% of the refrigerators inspected are actually WHO pre-qualified refrigerators. Okay, some more quality indicators. Refrigerators, it's an EVM requirement that refrigerators have more than just a thermometer. They have what's called a continuous temperature monitoring device, a 30-day temperature recorder that gives you the temperature of the previous 30 days, gives you the maximum and minimum temperature so that you can identify excursions and potential damage to vaccines. Less than 50% of the refrigerators inspected actually have these required devices in them. And even more scarily, it's recommended that whenever freeze-sensitive vaccines are transported in passive containers with frozen ice packs or conditioned ice packs, you should put in a freeze indicator to identify if the vaccine was exposed to freezing temperatures. And very, very few facilities are actually using freeze indicators when they transport freeze-sensitive vaccines. Okay, I'm just going to pick out one there. Knowledge of the shake test. This is a big issue. I actually thought that the knowledge of the shake test would be worse than the data shows, but it suggests that about a third of the health workers actually know how and when to conduct the shake test. The knowledge, according to the data, is slightly better at the higher levels of the supply chain. Efficiency. 3 indicators here, 3 efficiency indicators highlighted here. First one tells us that much more than half of the stores, the national stores, the regional stores, and the district stores have a fully up-to-date cold chain equipment inventory. So they're actually aware of all of the cold chain equipment they have in their own facility and the facilities that they deliver to. So there's still more than a third of the facilities are not actually aware of the equipment that they have. Another one on the positive side, over 90%, approximately 90% of the refrigerators actually inspected were fully functional. And the last one is quite scary. It tells you that at the time of inspection, about 25% of national stores were still using paper-based stock management systems. Of course, the situation gets worse as you go down into the supply chain. But at the time of inspection, there was still a quarter of the national stores using paper to manage their stocks. Lastly, about a third of the staff interviewed said that they did not receive regular supportive supervision, so they were basically left on their own to look after all of the vaccines. Okay, that's all. This slide here just gives you the various links to the different EVM websites. where you can actually download the larger version of this presentation, which has many, many more indicator scores and criteria scores. That's all. Thanks.
It's good to get this overview global overview, at least with numbers, to confirm the photos story that we saw, and that the supply chains aren't performing as good as we think they're doing. So to end this session on keynotes, I'd like to invite Raja Rao from the Bill and Melinda Gates Foundation, who's actually going to start looking forward. Now we've seen things, challenges, and what's happening now. But where are we going? What are some of the perspectives for the future when it comes to immunization supply chains?
Thanks, Patrick. Everyone hear me okay? Good. Thanks for giving me the chance to speak today. This entire presentation I did by myself, and that's going to be readily apparent very soon. The other presenters did a great job, I think, in covering kind of really the important topics that we're going to go into much more detail in the coming days. You know, it's interesting, I was just thinking back and writing this speech and making this presentation. This 2015 is the 20th year. I'm a lot older than I look, in working in international development. And I wanted to think about, one of the things I wanted to talk about today was our work in the context of international development. I've been working in ag, I've worked in education, family planning, HIV, malaria, and now immunization. I thought it would be interesting to take a little bit of a look back into that very briefly. And I wasn't sure whether it would be more useful to bring some of that perspective forward and connect it to the discussions about the prospects and opportunities of supply chain logistics, or just to talk about the success and challenges, or just to dive into the data. We've got the flavor of all of those, and I'm going to try to maybe pull some of that together with my own commentary. I still don't know the best way to approach this presentation as of this moment. I think that's going to make it a little bit interesting. We'll probably get a little bit of both. What I wanted to do, I think, above all else, is to make sure that I don't bore you. So keep that in mind. So what am I going to talk about today? Yeah, the slide is blank. The slide is blank right now. Thanks, James. So
That's the future. The future's blank.
the future is blank, right? I hope it's not, given all the work we've
It's
done.
an open book.
It's an open book, it's a blank slate, it's everything. And it's in random thoughts. That's where I was about a week ago. And so when my 15 minutes is up, maybe you'll think that I haven't gotten much further than that. I hope that's not the case. But random thoughts on the supply chain. I was speaking at TechNet, and I didn't want Patrick to disinvite me. So I said, well, I'm going to put in supply chain into my presentation. So of course, I'm going to talk about immunization logistics, where we were, where we are, where we could possibly go. Pressing the wrong button. So in the context of our work in global development, like I mentioned, there's a lot of things out there that people can do to improve what I call the human condition. Fixing fridges, making sure the data does what it's supposed to do, those kinds of things are just a couple of things in a universe of thousands. In doing some research for this, I found out that I didn't know, but did you know that some people say that reducing tax evasion is a more sensible intervention, or at least a more cost-effective intervention, if you believe in the link between economic growth and health, than say malaria reduction is. So I found out some new things. So who are we at the Gates Foundation if we fail to highlight innovation in the long road? I think innovation is important. We overuse the term, obviously, too much. I prefer creativity. But in addition to innovation, I think the pendulum needs to swing a little bit further to the middle, and we need to gain some perspective when we use that word innovation. I'll talk about a little bit why. This is why I think, I want to emphasize the point that there are no quick fixes in ensuring that vaccines are more available, they're more safe, they're more potent on the back of sustainable delivery systems, which, by the way, is the Gates Foundation's overall goal for immunization logistics. And finally, I will document some successes and perspectives on the future. I do want to say a thing or two about the great work we've done, especially over the last couple of years together. And I want to highlight how we can tackle the future. The future challenge is actually more collective. So random thoughts on the supply chain. In the context of our global development work, being creative, the long road, some successes, and the future is really what my presentation is about. There. Everyone knows this person. Albert Einstein said, everything should be made as simple as possible, but not any simpler. Just a quick show of hands. How many committees, how many sub-teams, technical working groups, etc. do we spend time on? 4, 5, 6, 7, probably too many. How much repetitive analysis do we do against the same problem? If someone says, hey, let's do this, and someone says, hey, that was done last year, and someone says, hey, we did that 3 times last year. How can we simplify? And, how much innovation and complexity? We've got a lot of complexity. We've got a lot of innovation. Do we need just because we can do it? Or maybe it works a little bit better in terms of achieving our goals. How do we know? When do we speak up? What do we say? Simplicity. I'm not here to criticize analysis. God knows we've done our fair share of it at the Gates Foundation. Or intelligence. There's a lot of it in this room. But I think we've got to create forums, to share, decide. We have to analyze a problem. We want to know how to solve it. We've got to be able to measure it. And a lot of our analysis has been great. I mean, Paul talked about the great work that's been done on EBM that sort of gives us an overview of the health system, the supply chain. We do a lot of cold chain inventories to understand what's working, what's not working. And a lot of our markets work in understanding how we can intervene in the global markets to drive down pricing has been phenomenal. I guess my point is, I just want to reinforce this notion, and I think I know, I'll take it from your silence, that really all of you understand what I mean when I pick on complexity, when I pick on innovation. I think that we have to purposely think about the balance between complexity and simplicity, as I think Einstein is saying, in the frame of what we're trying to achieve, the goals of what we're trying to achieve. What I took away from this was, I kind of reworded it in my own mind a little bit, and I said, be simple when you can and be complex when you have to. And to me, that's something I've always tried to follow. So this, who hasn't seen this? First one I saw was in Kenya, this one is Tanzania. And, what would Einstein think of this? What do you think of this? Going forward, thinking about your work, thinking about complexity, thinking about your goals, thinking about how to achieve. It's so complicated that, just to talk about it, we have to reduce it to this. And we often get caught up in, one of these boxes, just one, or in one vertical chain, and we don't see the whole picture. And this just struck me as, yeah, we've seen this, and yeah, it's, whatever. But at the same time, it's quite telling about thinking about and organizing ourselves as we go forward in supply chain logistics. I want to change gears here just for a minute, if you bear with me. Remember I said I wanted to take a step back and talk about global development. That's what I'm going to do now. Just about everything that we do at the Gates Foundation in supply chain logistics is to do one thing. Again, I'm speaking for myself. It's to reduce the under 5 mortality rate. That's what we want to do. Our theory, our strategy, in short, from the bottom up, is basically that our supply chain investments, the work that you do, the work that we do, leads to activities, things we do, which lead to outputs, better data, better fridges, more fridges, which in turn contribute to the outcomes that I think we've all agreed on, largely with the UNICEF, WHO, Gates Foundation, Gavi, and all of you, that we want more product availability, we want more potency, we want more safety, we want more sustainable, efficient systems. And we, really I think we do. it's always hard to speak for others. Think that this has a kind of a causal effect that's going to lead to improved immunization coverage and equity. So ultimately, that potency and safety is going to lead to that immunization goal around coverage and equity. But it doesn't stop there, because I think that helps us to achieve our goal of reducing child morbidity and mortality, along with the other things that we do in immunization, but along with the other things we do outside of immunization. Stunting, TB, malaria, migration, etc. And this sort of leads us to an overall improvement in the human condition. It goes beyond under 5 mortality. And so the message here is that what we're doing in supply chain logistics, fixing fridges, doing EPMs, rolling out LMIS, doing the training, ultimately should have a causal effect that goes through the system that helps us achieve under 5 mortality and ultimately helps us achieve that common condition that we're trying to aim for with a lot of other things in global development. So if you look at this slide, I'd argue that we have a lot in common with the people who tackle these things that you see on the page: malnutrition, malaria control, and even the trade bureaucrats under trade liberalization. You don't have to buy into the argument quite yet. That's not my point. A Danish economist, unnamed Danish economist, I have his name, doesn't matter, working on the post-2015 SDGs, Sustainable Development Goals, the next thing, the MDGs, says that the #1 value for money in development is to complete the current WTO treaty. You can argue with that, which he said would give developing countries $3,426 for every dollar that they spend. This is the proverbial best bang for your buck, the killer app, if you believe in some sense between the connection of economic growth and global and health. And his group goes on to say that contraceptives, as you can see here, for all who want them, provides $120 back in economic benefits for every dollar spent. Better nutrition, 45 to 1. I thought that would be higher. Clamping down on tax evasion, 49 to 1, and so on. There's a cottage industry, like I mentioned, that's grown up, many of you are probably familiar with it, that's grown up around these issues between investing in growth, economic growth, versus investing in global health. To try and kill the suspense, I think, like probably most of you do, that you have to do both. And I don't know where immunization stands on this list. I'll show you a little bit of data in a second that gives us an indication. But it's got to be pretty high. So what's my point? What's my point on this tangent? I guess what I'm trying to do is just to generate a little bit of self-reflection as we begin this week about sort of the commonality of approaches to improving under 5 mortality, to improving the human condition, and to help us prioritize and understand that, you know, our little world down here in supply chain is part of a much, much larger ecosystem. There's a wider world out there that's also trying to achieve the goal that sits on top of our pyramid in terms of improving the percentage of those living healthy, productive lives. And it gives us perspective. I think it allows us to get outside of ourselves for a moment and think about what we're doing. It gives us the ability to make judgments, to prioritize. And I think it helps us view the world through the eyes of the client that we ultimately serve, who are also worried about these things too on a daily basis, not just getting the vaccine. As crazy as that may sound, it's worrying about a lot of things that are going on in the world, which others are trying to improve. You've seen this slide or a version of it. We finally get to immunization. Why are we in this room? What's the value in lives and money we're working to preserve and extend? You know, making sure safe and effective vaccines are routinely available. I think we're doing pretty good. If you believe in this data on the value for money front in immunization, billions saved, introduction of these new vaccines and other pneumo, malaria, rota, etc. So, you know, we're up there as well. We're part of that larger ecosystem that I showed you before. Again, you know, you've seen this. Many of you live and breathe it. One of you probably even put this together. The global under 5 mortality rate has been almost cut in half since the end of the last decade. Lots of progress on neonatal mortality, infant mortality as well. And this is just impressive. To paraphrase from a recent IPAC publication out of Johns Hopkins, using the GIVS list tool, an estimated 6.4 million future deaths could be avoided this year onwards by increasing the coverage of just 6 vaccines: measles, Hib, pneumo, DTP, rota, malaria. And this has an estimated economic impact, going back to that other slide on economics, of $231 billion. Wow. So our success, everyone you see here, look around, are tasked with making sure that this becomes a reality. We play a huge part in this with supply chain logistics, so no pressure. I pulled all this stuff from sources at my fingertips. You guys have seen this stuff before. That's not really my point. My point is that the evidence is everywhere for what I just said. I know you've seen this a lot, but I think it's useful to do a gut check now and then. Coverage leads to less cases of illness, as you can see from the slides on the left, which leads to less mortality and morbidity. And my point, I'm going to leave this and talk about something else, is that, what we're doing works. It has a huge contribution to very, very big things that we don't often discuss. Vaccines work. I know we said that before. There's a Twitter tag called Vaccines Work. And supply chains, the reason we're here, they help make vaccines work. We're tasked with making sure, those of us in this room, with making sure that it all kind of comes together. It's a really, really profound responsibility. So you're all kind of probably thinking, let me see if I get this straight. I'm going to recap for a second. Keep it simple, but not too simple. How many of those Tanzania, Kenya supply chain wiring diagrams are we going to see? At least he's not asking me to do anything about it right now. It takes the proverbial village, multiple disciplines to decrease the totality and inequity of suffering. And lastly, as I said, immunization works, and supply chains are key for immunization programs. So ergo, we have a big role to play, at least that's my takeaway, in decreasing sort of the totality of human suffering. In other words, I'm trying to make the moral case for supply chain logistics in my own way. So how does your work, my work in logistics play a part in this broader question? I'm told, and I believe this, that we can't yet prove that supply chains are sort of causally related to coverage. Fair enough. Therefore, I can't make that leap between our work and sort of the under 5 mortality and the broader goal of healthy and productive lives. And so what do? Should we just all sort of go home right now? Because the causal chain doesn't quite fit. Of course not. I don't think that's true. Maybe we don't have all the data to statistically prove it, but we know that immunization logistics are the backbone of the immunization program, without which coverage really can't happen. To sort of borrow the phrase, vaccines don't deliver themselves. So where do I begin on progress? Luckily, it's not a blank page on the progress that we've made recently. That's good. Are we on the right track? We're making progress to support the opportunities and that theory I put forward about the causality of what we're doing leading to much bigger things. I think we are. I think we're at the point in time, things are really coming together. I think that's clear from all the discussion I've had, everything we've witnessed. We've realized the enormity of our responsibility, kind of what's at stake. I think we've begun sort of putting in the processes and plans that are going to set us up for success. We're turning the slide decks, this is a conversation I had this morning, into kind of a two-dimensional analysis to something that's three-dimensional, maybe even more, actual things that we're doing now. We've got the first ever Gavi Alliance supply chain strategy, of which I think everybody in this room is a part of, even if they don't know it. It's helped us sort of separate the important, critical, the essential, nice to haves. We're working on country-specific approaches. I think, and above all, we're kind of we've raised, I think, a lot of the work Patrick Brothers pointed to, the SAGE call to action last year, of the kind of the primacy, the centrality of supply chain logistics, the level of policy making and financing, to quite frankly, I think, at a level at which it hasn't seen before. And I think that's when we're really going to start to make progress. And we can communicate to people who don't really know a thing about what we're talking about, but we can communicate to them the value of what we're doing. That's going to be key. The hub, you mentioned that, and Benjamin are leading that. As UNICEF and WHO are really taking on the task of emphasizing their global leadership responsibilities by creating, I think, what is an integrated agenda between sort of the global practices, a lot of the things happening in this room, and the impact they can have at country level. That's the immunization supply chain logistics hub. Many partners in this room are also developing and deploying information technology systems to improve the availability of logistics data, like a program that I was involved in and still continue to be called the Electronic Vaccines Information Network, or EVEN, will be rolled out in India with Gavi and UNICEF support to help manage the vaccine supply chain for almost 500 million people across 5 states. That's going to be historic. On system redesign, we're also working on making systems more responsive, more efficient, by restructuring and get vaccines to the clinic faster with dedicated transport. We're thinking about how to integrate the data management piece with the structural piece around system redesign. And a number of partners in this room, AMP, Village Reach, others have been very active in these areas. And on new technology, I think, within the kind of the confines of what Einstein's guidance is saying, is also playing a big role in opening up new opportunities with testing and deployment of remote temperature monitors, with fridges that keep vaccines cold for days without power, and adaptation of mobile technologies. But I consider this smart innovation. I consider it targeted innovation for actually addressing the very practical problems that we're seeing. And finally, in terms of innovation, and I'll stop saying that word, is that we at the Gates Foundation are really taking a hard look at some of the things that we can do to help the supply chain that are not necessarily intuitive in terms of when you think about trucks, distribution networks, and so on. But we're exploring how improvements to vaccine delivery devices themselves, the vials, the needles, etc., and researching the more thermostable vaccines and products can contribute to our mission. Making devices smaller, more easily handled by healthcare workers, which isn't always synonymous, and more thermostable properties to extend coverage beyond what the traditional boundaries have said that we can do, are just some examples of how we see creativity raising its head and playing a role. Finally, I just wanted to mention, just last week, the Gavi Program Policy Committee of the PPC, which many of you may have heard of, approved several $1 million, up to $50 million, to procure cutting-edge cold chain equipment that's less costly to operate, preserve vaccines longer, more safely. To me, that's a very big victory and a very practical victory. And I can go on and on. But this week, I think it'll be important to just take a minute to reflect on the successes we've had. There's much more than what I just sort of highlighted. But I think the key thing is, and I think I'll raise this in a second, is that we've got to work together. We've got to realize our strengths, our weaknesses, our comparative advantage, and figure out how this can all come together seamlessly. So we're still at the beginning, another blank page, hopefully maybe not. But much of what I talked about in terms of our successes, to be frank, I think it makes us real dents in the problem. But they're tools, they're processes, they're outputs, all necessary, which I think are the precursors to the actual outcomes that we're going to want to see in immunization. Ultimately, how do we reduce stockouts? What do we do to get there? What are the activities and their sequencing that ensure, for example, safety remains paramount as we deploy new devices, modified delivery systems? Very quickly, I think we have to be creative. I think we have to be inventive. We shouldn't just follow the crowd as that one fish is doing, found a bigger bowl. And I think we have to take the long road and understand that, while we've been doing this for a while, we have to have some perspective. And then finally, I think we have to make sure that whatever we do has to work at country level. We should avoid errors of judgment. This might work in the lab, but it's probably not going to work at the clinic. Like I said, I think we all have to work together. We have to work collaboratively together. There are many more organizations here represented in this room. We've got to understand our specialties, our skills, our strengths, and our weaknesses, figure out what you're going to do, what you're going to do, what you're going to do, and then just kind of just get on with it. Thank you very much.
Thank you, Raja, for your thought-provoking and that self-reflection presentation about the future of immunization supply chains. The message about reducing complexity, make it simple, as Einstein said, don't make it any simpler. How to remove those barriers, scale up, how to prioritize. But the fact that there's a lot of new initiatives, solutions out there, there's ways to address these things. So, and a lot of these will be discussed actually this week throughout the conference. So, and because we're sort of behind schedule on this, I'm going to propose that we're going to have a moderated discussion with some questions and answers. I think we will have ample opportunities throughout the week to discuss more in depth. And I know that the people are waiting outside for the welcome reception. We need to get started, and I know some of you are probably starting to feel the jet lag. And so I would like to just take a few minutes to actually walk you through the agenda of the techniques so that you get a sense of what's waiting for you this week, and just a little bit of some guidance. I'll try to make this quick, but I'm sure most of you have received the conference brochure. Just to let you know that there's been a lot of people involved in preparing and planning for this conference. I can't name everybody, but there is an acknowledgement section in this document that highlights the main players that have been responsible for putting this together. But there has been an organizing committee composed of members from PAB, from JSI, people that deliver the gathering. This is being organized and co-hosted under the umbrella of the WHO and UNICEF HUD. Just to let you know that there's various events happening in the conference. We try to make this very interactive. We've been trying to do things a little bit differently than what has been the traditional way of conducting meetings and consultations and conferences. So because of that, I feel the need to actually walk you through how this is going to play out, since it can be perceived as a little bit complicated. But just to let you know that on the beginning of the conference brochure, you get at least some indications of the different events that are happening. There's sort of a formal agenda, but there's also a lot of side events. And because there's a lot of things going on at different times, we even had to provide a map so that you can figure out where to go and when. Okay, so just that's going to keep you busy, just trying to figure out where all these things are happening, and probably having you move around different floors and different things. That way you'll be able to keep awake from and fight off the jet lag. But just to give you a sense of how the agenda is being worked out, we had this opening ceremony and the keynotes, and this is really to just give you some context around the theme of the conference, which is immunization supply chain. We're then starting tomorrow, for the next 3 days, we're going to talk about some of the current challenges and some of the innovations that we're seeing in immunization supply chains. And within these current challenges and innovations, we've broken every day in terms of a theme. The first theme tomorrow will be around designing the supply chain. What are the factors needed when you're thinking about that? And there's 2 topics. One of it's about just fixing some of the basics. No matter what the design of the supply chain is, you need to maintain some of the basic vaccine management practices. But you also need to explore, do you try to redesign the network? Do you design your supply chain by trying to integrate with other health commodity supply chains? Do you design your supply chain by engaging the private sector? What are these key elements around designing your supply chain? And those will be topics that will be covered tomorrow and Tuesday. On Wednesday, it's about equipping that supply chain. It's all about cold chain equipment, about temperature monitoring, about maintenance systems, and all of these. And these are the topics that are going to be covered when it comes to the main areas of equipping the system. And then the Thursday, we'll talk about managing the system. So you can have the best design, you can have it all nicely equipped, but if you don't have people, if you don't have the data to manage your supply chain, it's not going to work. Right? So the topics around Thursday are going to be around human resources for logistics, data for management. And Friday is going to be a half a day. We're going to be talking about what are the components, the elements that are going to enable change within the supply chain. And these will be about future perspectives. What are some of these innovation solutions and initiatives that Raja mentioned in his presentation. So that's sort of how the agenda is being structured around each day. There's a theme, designing the system, equipping the system, managing the system, and how do you enable it to happen. It's going to cover 2 topics every day. It's going to cover topics around current challenges and innovations. Right? So I hope you can bear with all of this. Now it gets quite complicated in the mornings. Everybody's going to be here in this room. It's going to be a plenary session, okay, where for those 2 topics that are being covered, there'll be some global updates, and then they'll be followed by specific country presentations that are going to illustrate some innovations around that topic. So for instance, if we pick network design or system optimization, we'll hear about some country experiences of having done it. For instance, we'll even hear from Thailand, who decided to outsource their supply chain to the private sector. And what do we learn from some of these things? And of course, at the end, we'll have the global updates, the country presentations, and they'll be followed by some questions and answers. In between, of course, there'll be a coffee break. Okay? So each day is going to have that similar format, where there'll be some global updates around that topic, some country-specific presentations, and then some Q&As. When you get to lunchtime, everything starts getting interactive. Okay? It's not a format. We're no longer sitting in a down. There's of course the lunch, so you can go have some lunch. But of course, every lunchtime is going to be there's going to be a 2-hour session between 12 and 2 is the lunch break. So you get 2 hours. 2 hours to either have your lunch or pick and choose. Some of the side events are going to be opening up. There's the Manufacturers Corner, there's the Innovations Cafe, the Project Gallery, Video Gallery, the TechNet Clinic, and the Resource Library. And all of these are explained in the guides what they are. But just to note that during lunchtime, there's actually formal sessions happening around that. In terms of the Innovations Cafe, which is happening outside, you know that during lunchtime, there'll be 2 innovations that are going to be demonstrated outside in the Innovations Cafe area. In the Project Gallery area, there'll be 5 speakers that will be speaking around their posters formally during that session. Okay? And there'll be a person speaking around the video gallery. Okay? So during the lunchtime, there's a lot of things happening. You can pick and choose what you want to do. You're not obligated to go to all of them. You just figure out what are the ones that interest you, but you need this guide to know when these are happening. And of course, there is one roundtable discussion at lunchtime. Robert already sort of advertised the one that's happening tomorrow. But every lunchtime in the New York group, there's a 1-hour roundtable discussion for those that wish to join it on a specific topic that's relevant to the theme of the day. Okay. Have I thoroughly confused everyone with the agenda? Okay. The afternoon, you're going to have a menu of, so that was lunchtime, right? So it just gets even more complicated after lunchtime. Lunchtime, you'll have sort of sets of hours between 2 and 3. You'll have 3 events happening simultaneously. You have to pick one. You can go to an expert panel discussion, or you can go to a focused breakout. But those are going to be topics that are relevant to the topics of that day. Just going a little bit deeper than what we heard in the morning in terms of global updates and country presentations. These will be interactive sessions. between 4 and 5, there's another round of interactive sessions where you pick one of the 3. In between, you have a 1-hour coffee break to sort of breathe a bit and allows you to kind of explore these other side events happening alongside. Okay. So just wanted to highlight that there's a lot of participants coming to the TechNet now, so it's kind of hard to, we need to have a lot of variety so that people's interests are covered, because not everybody's interested in every single topic. So of course, this is why we chose in the afternoon to make interactive sessions so that you can pick and choose based on what's most interesting to you. But of course, it means that there's more choice. So it means that you have to make choices in terms of what you want to see. You can't see everything. So just to recap, that in the afternoons there'll be 6 formal interactive sessions, which you'll only be able to see 2. The side events are open, but the formal presentations are at specific times. So you're going to have to figure out what is the menu that's suitable for you. Go through the guide and select what are the sessions I want to do, and you construct your own agenda in the afternoon. Okay? So in the morning, we're imposing an agenda. In the afternoon, you have a menu of choices, and you need to pick and choose what's